One, please start, sir. We are live.
Yeah. Good morning, everyone. Thank you for joining us on this Sunday. We have our hematology update session, second part of the session from 11 to 1, and we have an esteemed panel of doctors to discuss with us varied topics on the hematological diseases that are prevalent and are most commonly encountered uh, in our setting in our country all this while. So uh, we have obviously Dr. Rahul Sood sir, who would be the moderator for this session throughout the session as well as for the case discussion. And we have the scientific partners of AstraZeneca supported by Intas Oncology and Lilac Insights as well. Coming to the agenda of the session, we have with us, we'll start off with Dr. Rahul Sood sir setting the ball rolling for the upcoming talks that are going to be scheduled for this session. And then we have Dr. Aniket Prabhudesai sir, who will take us through the risk stratification and role of.
I don't think we can see the agenda. We can just see the scientific partners, if I'm not mistaken, right now. Can you see the agenda?
Not it, sir.
I think you need to protect the agenda.
Just a second. Is my screen visible? Hello?
No, sir. I'm sharing. Sir.
Yeah.
Yes, sir. Start, please.
Sure. Thank you. So the agenda is as seen on your screen right now. We'll have Dr. Rahul Sood sir setting the ball rolling in a few while, following which we have multiple sessions, starting off with Dr. Aniket Prabhudesai sir, who is the Senior Scientific Officer for Lilac Insights Private Limited, who will take us through the risk stratification and the role of prognostic markers in the management of chronic lymphocytic leukemia. Followed by which we'll have Dr. Rajat Bajaj sir, who will be taking us, who's a consultant and hematologist and bone marrow transplant physician from HCG Manavata Oncology Hospital, Nasik, who will talk us through what is the role of chemoimmunotherapies in the management of high-risk CLL. Following which we have Dr. Meet Kumar, a consultant Department of Hemato-Oncology and Bone Marrow Transplantation from Fortis, Gurgaon, and he'll be talking on acalabrutinib, the second generation selective BTKI, and its role in previously untreated and relapsed refractory chronic lymphocytic leukemia. Following which, there will be Dr. Amit Upadhyay sir, who will be taking us through the talk on MCL at first relapse. Dr. Amit sir is a senior consultant hematology at QRG Super Speciality Hospital, Faridabad, Haryana. And following which will be the case-based panel discussion on real-life case scenarios of CLL and MCL, of which Dr. Rahul Sood sir will be moderating the session, who's a consultant Department of Medical Oncology from Command Hospital, Air Force, Bangalore. And the panelists will be Dr. Rajat Bajaj, Dr. Meet Kumar, Dr. Amit Upadhyay, and Dr. Aniket Prabhudesai sir. It is a privilege to have you all here. And once again, I would like to welcome you all and looking forward to an insightful discussion. And to the speakers and the panelists, it's a privilege to have you here all. Dr. Rahul Sood sir, over to you.
Thank you very much. I welcome you all on this Sunday morning brunch session, if I can call it, because we are midway between the lunch and the breakfast. And I think this is the apt time because we're all at home, and the best way to fill ourselves is with knowledge. And no better to learn about hematology and two most important hematological malignancies that we see, and we are happy to see, because they are those malignancies which give us time. We have options available, and they respond beautifully to treatment once we do it. A lot has been happening in both CLL that is the chronic lymphocytic leukemia and lymphoma, and the mantle cell lymphoma. So it is apt for us not only to learn about what is going on in these two diseases, but also to learn from our colleagues, that is our pathologists, microbiologists, and obviously from one another, that how do we manage these malignancies in 2022. We know that the chronic lymphocytic lymphoma is an important lymphoma leukemia in India. It was initially thought to be a westernized disease, but as we ourselves become more westernized, we are seeing this disease happening. It was a disease of the older age groups, but now we see a paradigm shift where the disease is coming even in individuals who are nearing their 50s. The mantle cell lymphoma, again, which is a cousin of the chronic lymphocytic lymphoma, is another important disease. Why? Because the presentation may be varied in this. It may present with either lymphadenopathy or an extranodal presentation. Majority of these diseases, that is the CLL as well as MCL, may just present with constitutional symptoms upfront, which may be neglected over a long period of time. So this leads to upstaging of the disease and thereby complicating the treatment which is there. Therefore, it is important to diagnose these diseases early when the constitutional symptoms start, when the bone marrow is well preserved, when the organs are well preserved, and the performance status of the patient is good, so that apt treatment can be given. So therefore, today's meeting is not just to sensitize what are these diseases, but to also update ourselves on what is happening in both these diseases. So with this, I welcome you all once again. I've set the ball rolling as I was told to, and I hand over back to Akash to start introducing the speakers one by one. They're all elite speakers, and looking forward for a very, very good session in the morning. Over to you, Akash.
Thank you, sir. So up front, we have the first talk of the day, which would be by Dr. Aniket Prabhudesai, sir, and who is the Senior Scientific Officer from Lilac Insights Private Limited. And he'll be taking us through the topic of risk stratification and role of prognostic markers in the management of chronic lymphocytic leukemia. Dr. Aniket, sir, over to you.
Thank you so much. Thank you, Dr. Akash. Thank you, Dr. Rahul. Good morning to one and all. Am I audible? Just wanted to confirm and whether the slides are visible.
Yes, sir. You're audible and the screen is visible.
Screen is visible, right? Okay. So good morning again, once everyone. So I'll be talking about risk stratification and role of prognostic markers in CLL. So CLL, as we know, is a blood cancer involving lymphocytes, and it is more specifically a mature B cell neoplasm. And the tests that are used for diagnosis, generally it is a incidental finding in CBC where it is picked up, increased WBC count followed by a smear evaluation, which shows enlarged lymphocytes. And another method by which we can go for providing a definitive diagnosis is immunophenotyping. CLL cells express membrane phenotype of generally the early B cells, and they express CD5, CD19, CD20 weak, CD23, and weak surface membrane immunoglobulins. The main criteria is more than 5 into 10⁹ cells per liter of absolute B lymphocyte count, which will help to diagnose a CLL. Clinical presentation, it could be constitutional presentation symptoms mainly. It could also be something called as lymphadenopathy, which is one of the major presentations seen in some of the patients, and followed by splenomegaly, hepatomegaly. A bone marrow aspirate and bone marrow biopsy are generally not required for the diagnosis of CLL. So this is the immunophenotype of CLL, wherein you can see there is presence of CD5, CD19, weak expression of CD20, serum immunoglobulin light chain, kappa or lambda. And so there are 3 different groups that CLL can be divided based on the symptoms. So first group is patients who never require any treatment and do not have a long survival. Second group is a patient where they have indolent phase disease and which later on progresses and becomes aggressive. And third group of patients are patients with aggressive disease requiring an immediate treatment. And for the prognostic assessment for individual patients, there are a numerous range of factors which I'll be discussing. So the first is age. So advancing age is a predictor of poor CLL outcome. As you can see in the Kaplan-Meier curve, as the age progresses, you can see that there is decrease in the median overall survival rate. Physical fitness and comorbidity status. Again, physical fitness and comorbidity is an important predictor. It is generally can be given by the CIRS score, which is the cumulative illness relative scale for physical fitness and to assess the comorbidity status. So based on that, they can be divided into 3 different subgroups based on the physical fitness, comorbidity, and life expectancy. And based on that, the therapeutic goal can be determined. So talking about how are genetic aberrations detected in CLL. So there are 3 different ways. First is conventional karyotyping. We are doing a comprehensive analysis of the chromosomes or the genome, and we are checking for presence of any numerical or structural changes. In this picture, you can see there is a 13 arm deletion and 11 arm deletion. And second is interface FISH method, fluorescence in situ hybridization, is more of a targeted way to look at changes, basically chromosomal abnormalities. It can detect chromosomal translocations as well as some deletions as well, based on targeted sequence, targeted way of designing the probes. And the third technique that can be used is next generation sequencing, which is recently being coming up very much for diagnosis of different mutations, as well as the conventional Sanger sequencing, which is generally available in most of the laboratories in India. So talking about FISH is a cytogenetic technique where we are using different probes. These probes are made up of complementary DNA sequences and they have a fluorescent tag. So they will go and hybridize on the chromosome of the region of our interest. And based on that, wherever it is hybridizing, we will come to know whether that particular region is missing, or based on the pattern of the signal, we will come to know what kind of changes are happening at the chromosomal level. It can help in detecting translocations as well as it can help in detecting deletions. Another important point and an advantage of FISH over CK is that it can be used on FFPE tissue, wherein CK requires dividing cell. So just why do we use FISH in CLL? Because it gives a prognostic outcome. So FISH is basically not a diagnostic cell test for CLL, as it can be found in these anomalies can be found in different lymphoproliferative disorders as well. But 13q deletion has been associated with a good prognosis. Trisomy 12 has been associated with the intermediate or a neutral prognosis. 11q deletion is associated with a poor prognosis, and 17p deletion or p53 deletion, gene deletion, is associated with a very poor prognosis. So that is why we get a prognostic outcome when we use FISH markers. So this is a example where you can see that on the Kaplan-Meier curve, you can see that 17p deletion is associated with the worst overall survival median, followed by 11q deletion. Next, talking about next generation sequencing. So next generation sequencing has been able, I mean, it is a very good blessing which has helped us identify numerous genetic markers at one time at a less cost as compared to Sanger sequencing, and at a lower frequency as well, the lower frequency rate, variant allele frequency rate. And TP53 mutation is one of the markers that is that can be diagnosed with the help of NGS. And generally at diagnosis, patients have CLL patients have been found to have almost like approximately 9% frequency of showing TP53 mutation. But the increase in the TP53 mutations is very increased, up to 30-40% in patients who have relapsed. So it is very important to go for TP53 mutation. IGHV mutation status can also be done by Sanger sequencing as well as next generation sequencing, and NGS can be used to detect other mutations like Notch1, SF3B1. So many mutations can be covered at a single go. Talking about TP53 in CLL, so there are two things. One is 17p deletion, which can be detected by FISH. So there is complete loss of the P53 gene. And second is something called as mutation, TP53 mutation. So these two are both different. So what happens in 17p deletion is there is a deletion of a short arm of a chromosome number 17, whereas mutations are basically changes in the DNA, in the gene sequence of TP53, which will lead to formation of an abnormal protein, which will not have the normal function of TP53. So there have been studies which have found that P53 mutations, if P53 deletions, CLL patients with P53 deletions may also have something called as TP53 mutations in the another allele. So it basically in such a scenario, it will lead to biallelic inactivation of TP53. And this is associated with a shorter progression survival, overall survival, and TP53 again mutation or deletion presence. The conventional chemoimmunotherapy may not work in those patients. So this is just a comparison based on a study. So you can see that TP53 alteration, that is both TP53 deletion or mutation or both of them, have a overall survival, a very low overall survival. And when it is combined biallelic inactivation, it will have a worse prognosis as compared to individual P53 deletion or mutation as well. Next, we talk about something called as IGHV mutation status. So what we are basically doing is we are the rearranged immunoglobulin. We are amplifying it with the help of primers, and we are basically checking the variable diversity and joining region. So we are checking whether any mutation has happened in these genes or no, any somatic hypermutation. If there, so this is what we are doing in IGHV mutation status screening. We are comparing it to the germline IGHV status, and if there is a variability of more than 2%, that is known as something called as IGHV-M or mutated IGHV, and it has been found to be associated with a good prognosis. When we talk about when the difference is below 2%, difference between the CLL gene, which has been a patient whose IGHV has been screened, sequenced, if that difference is below 2% in comparison to the very germline sequence, it is generally associated with a poorer prognosis. So this is just a mere Kaplan survival curve where you can see that unmutated IGHV status has been found to have a lower overall survival in comparison to the mutated IGHV status. Definition of high-risk CLL. So CLL has been considered high risk if there is disease refractory to purine analogs, if there is any relapse within the 2 years after chemoimmunotherapy, or if there is presence of a deletion or an mutation, or basically TP53 aberration. There are other factors also associated with high-risk CLL, CD38 expression, then we have ZAP70 expression, beta-2 microglobulin. These are associated with a poor prognosis. Then we have Notch1 gene mutations. Notch1 gene mutations are poor prognosis, and in association with trisomy 12, if they are present, it has been found that it may have a higher incidence of transformation to Richter syndrome. richest info. And we also have something called as SF3G1, SF3B1 gene mutations, which are also found to have a poor prognosis. So CLL patients, they have been based on the clinical course. They have been classified into staging systems by two different scoring systems. One is RAI and one is Bennett. So if there is a C Bennett C score or a RAI 3-4 stage, which is generally associated with anemia or thrombocytopenia, then those patients are found to have a higher risk CLL. So CLL can transform into something called as an aggressive lymphoma like DLBCL, and though the occurrence is low, 1 to 2%, 3%, but it still can lead to an aggressive disease, and the treatment may be refractory in such case. So that is why it is important to do screening of TP50 fish markers and IGHV mutation status in patients with CLL. So based on the NCCN guidelines have provided some prognostic markers that has to be screened, should be screened in CLL patients. Two of them being TP53 mutation analysis and IGHV mutation status. So if IGHV mutation status is found to be mutated, then it is associated with a favorable prognosis, and a TP53 mutated gene is associated with the unfavorable prognosis. There are certain flow cytometry markers like CD38, ZAP70, whose increased expression has been associated with a poorer prognosis. However, these are now very less used. We then have something called as fish markers, which will give us an idea where the presence of some like 17p deletion or 11q deletion, it may be associated with an unfavorable prognosis, and 13q deletion is associated with a favorable prognosis. We also have something called as complex karyotype. So checking for the conventional karyotyping, and if it turns out to be a complex karyotype, it may be associated with an unfavorable prognosis. So there is something called a CLL IPI index, which has graded different prognostic markers and given a score, which that score has been associated with the risk of grading. So if a score of a patient has a score of 7 to 10, so it has been associated with a very high risk. 4 to 6 has a high risk. So these patients need to be taken for treatment immediately. If it is a low score, then there is something called as wait and watch approach taken for these patients. So if there is a TP53, as you can see, that TP53 mutation or a 17p deletion is associated with a very high grade 4 score. So if there is any presence of TP53 mutation or any TP53 aberration, it will generally lead to a high risk in CLL patients. So that is why there is also possibility that if only fish markers are done, the 17p deletion may not be present. However, there could be possibility that TP53 mutation is present in that patient, so it might be missed. So hence, it is very important to screen fish markers as well as IGHV and TP53 mutation status CLL patients. So to conclude, CLL is most common type of leukemia and one that patients may never require treatment. There are different age, physical fitness, comorbidities. These are various factors that may have a poor prognosis in patients with CLL. Then, as per the NCCN guidelines and the CLL IPI score, it is important to screen for fish markers and IGHV TP53 mutation status, because 17p deletion, 11q deletion, TP53 mutated gene and unmutated IGHV status have been associated with a poor prognosis. Other markers like CD38, ZAP70, Notch1, beta-2 microglobulin, they also have a risk of have a higher risk of in CLL patients. So that's it. So what is the take-home message from this is that CLL patients at diagnosis or before starting on treatment, we need to screen them for FISH markers, for IGHP mutation status, and for TP53 mutation analysis as well. That's it from me. Thank you so much.
Thank you, Dr. Aniket, sir.
Thank you.
That was a comprehensive presentation on the biology of the high risk factors of CLL and the clinical implications of the same. That is an insightful session indeed. So audience, the next talk will be by Dr. Rajat Bajaj, sir, who is a consultant hematologist and a bone marrow transplant physician from HCG Manvata Oncology Hospital, Nashik. Rajat Bajaj, sir, has done his MD Hematology from AFMC, followed by the post-diploma fellowship in hematology from Tata Medical Center. Sir, it's an honor to have you, sir. And Dr. Rajat Bajaj, sir, will be taking us through the role of CITs in the management of high-risk CLL. Over to you, sir.
My slides are visible?
Yes, sir.
I think there's a problem with my camera. So anyways, due to the paucity of time, I'll just begin. Thank you, AstraZeneca, for inviting me. Hematology Oncology Update Part 2, Dr. Rahul Sood for organizing this. So I've been allotted the role of CIT in high-risk CLL. So in the next 15 minutes, I'll quickly go on with current treatment guidelines and current treatment methods which we employ for high-risk CLL. So also we've now moved on to recognizing CLL as a single entity and start recognizing CLL as multiple sub-entities with different prognostication. It's almost 1/3 of the patients were requiring treatment, and with the unfavorable ones having an overall survival of 2 to 3 years. So how do we prognosticate? We've seen that in detail in the last talk. We've got FISH, which can divide into unfavorable, intermediate, and favorable. The bad ones are deletion 17 and deletion 11q. Intermediate prognosis and patient normal cytogenetic and FISH. Deletion 30q as a single abnormality gives a favorable prognosis to the patient CLL. However, our prognostication is not complete because we have to also see the TP53 gene, which is a long gene. If it's wild type, it's favorable. If it's mutated, it's unfavorable. TP53, it can have point mutations which cannot be detected easily by FISH. So we have to sequence the entire gene. Also, we know that IGHV mutated CLLs do much better and they have a favorable prognosis, whereas the IGHV unmutated, they have an unfavorable prognosis. And patients with complex type, they're going to do worse as compared to the patients who've got normal karyotype. Now, based on this, we also have a CIPI score or the CLL IPI score. Apart from the clinical criteria like automatically counts, symptomatic symptoms, and autoimmune phenomena, we also use CLL IPI score nowadays to determine if the patient needs treatment and what treatment would he benefit the most from. So the patients who have got age more than 65 years, higher clinical age, B or C, RAI 1 to 4, high serum microglobulin, unmutated IGHV status, and TP53 mutated status. They've got poor prognosis, and based on this, the scoring has been made, designed to divide the patient into low risk patients, intermediate risk, high risk, and very high risk. So for lowest intermediate risk, there is no treatment required if the patient is asymptomatic or if the patient has minimal symptoms. For high-risk patients, treatment may be initiated if the patient has got mild symptoms or the patient has the clinical criteria of requiring treatment. For very high-risk patients, the threshold of treatment is extremely low, and we need to initiate the treatment as soon as the patient is symptomatic. And for these patients, conventional immunotherapy might not work, and they might need something more. So let us go on to what the treatment guidelines and what the studies say. So this has been the treatment evolution for CLL. Back in the 1960s, 70s, we had the good old Doramus and cyclophosphamide, Then came the nucleoside alkylators, fludarabine, pentostatin, cladribine. Fludarabine still used in the country. Fludarabine for younger patients, used for extreme patients. And then in the 2000s, we had the modified alkylators and era of chemoimmunotherapy, where we started using fludarabine, rituximab, adalimumab, and lenalidomide. So last decade has been the decade of targeted treatment. So in 2014, we had approval of various drugs. Most important ones, the Bruton kinase inhibitors, Bruton first in class, Bruton second class, PI3 inhibitors, idelalisib, dualisib, do not have access to currently in the country. BCL2 inhibitors, which is a venetoclax, and obviously non-CD20 monoclonal antibody, which is the opioid. And last year, we had 2 more drugs which have been included in the NCCN and approved by the FDA, which is the line BTK inhibitor, zanubrutinib, and PI3 inhibitor. And basically, no treatment evolution is complete without the inclusion of CAR. So its trials are in place, and we might soon have approvals and access to for CAR-T for CLL. So, immunotherapy era, what is the treatment methodology? Young patients, FCR is the treatment of choice for older adults, based. And in era, we have the Bruton inhibitors and BCL2 inhibitors, which is suitable for oscillation and have been approved for almost all the CLL patients. So, what the unmet needs here? So, first is for unfit patients, what is the treatment options available with us? So, there are many adult patients with CLL who might not tolerate chemotherapy-based regimen very well. So, safety profile of this chemotherapy remains questionable, and we need something more for the patients that are safety concern. And next unmet need is what are the treatment options which we have for patients of relapsed refractory CLL. So there are a group of patients who will respond to chemotherapy, however they do relapse in 2 years, 3 years time. So we need to address these questions of the availability of newer drugs. We are also seeing patients living longer. We need better treatment options for such patients. Now, looking on the study, is the FCR 300 study, which shows the PFS of patients with IGHV mutated states and IGHV unmutated states. So you can see that the curves are clearly separating, and the progression is survival for patients who are IGHV mutated is close to 4 years, and for patients who are IGHV unmutated, the curves start going down very low, and the progression survival is only 12 months. And so this is CLL trial, which shows the comparison of FCR with SC. So when the rituximab was in trials, the trial was conducted. Simulation of rituximab made a difference in high-risk treatment-naive patients. So clearly, as we can see, both the curves have separating PFS. So with the addition of rituximab, however, the one in the dark blue, the 70p deleted arm, even the addition of rituximab, the outcomes are not as good as you might expect. And what difference in overall survival? In 17p deleted CLLs did not do as well compared to the patients who are 17p deleted with the addition of rituximab. And what was the long-term survival as far as the IGHV mutated patients are concerned? So for patients who received FCR with IGHV mutated, they did very well, and they were almost considered operationally cured. For patients who were treated with FC without rituximab, they did not do as well. And for patients who were IGHV unmutated and treated only with fludarabine cyclophosphamide, they did poorly. So the addition of rituximab did make a difference. However, we did not have enough outcome responses for 17p deleted patients. What was the safety safety data as of fludarabine cyclophosphamide as compared to FCR? Not much of a difference. For patients who received rituximab, they had a slightly more individual toxicity and slightly more infection. However, grade 3, grade 4 infection was still low. Then came the CLL-10 study, which showed comparison of FCR versus rituximab, and it was a randomized phase 3 trial, which one standard patient involving 282 patients in FCR and 79 patients in rituximab. The primary endpoint was progression-free survival. The secondary endpoint was overall survival and quality of life assessment. So the median observation time was around 5 years or 58 months, and so there was a difference between the difference in the outcomes in the patient who received SCR versus BR. Median PFS was 47 months in patients who received SCR, and it was 42 months in patients who received BR. However, the 5-year overall survival, which was the secondary endpoint, was not significantly different. In fact, the patients were more than 65 years. The BR arm had a better OS as compared to SCR. As far as safety is concerned, there was much of a difference. There was slightly higher rate of secondary AML MDS. Patients more than 65 years of age were treated in FCR. So, what was the conclusion of the trial? That after median observation duration of 8.2 months, the median PFS was significantly better in patients who received FCR, was 37 months as compared to patients who received BR. Most common cause of death in patients who received the BR treatment was CLL, reverse formation, and secondary pregnancies in the SCR arm. There was no difference in health-related quality of life, which was observed with the treatment arm. So, the conclusion of this trial was if the patient is less than 65 years, he should be treated with an FCR-based regimen, and if the patient is more than 65, then BR is a very good alternative. Now, came the CLL-11 trial, which compared chlorambucil alone versus chlorambucil with obinutuzumab versus chlorambucil with rituximab. So, as we can see in the first picture, the chlorambucil versus chlorambucil obinutuzumab was a clear difference of 26.7 months as compared to 11 months in the PFS. And yes, not much different. However, there was still a difference between the chlorambucil and O-chlorambucil arm. Likewise, the outcomes were similar in the rituximab arm. The median PFS was 26.7 months, and there was not much of a difference in the overall survival. And what was the safety assessment? So, patients with what was the response and safety assessment for patients who received only chlorambucil? The overall response was 31 months. For patients who received obinutuzumab, it was 77 months. For patients who received rituximab with chlorambucil, it was 6.7 months. And there was also a difference in the CRs. None of the patients went into CR. And 22 patients who received with obinutuzumab went into CR, whereas patients who received rituximab with chlorambucil went to a complete CR. Not much of a difference between obinutuzumab and rituximab. Infusion-related toxicity was slightly more in the obinutuzumab. However, hematological toxicity was more or less the same. So, coming on to the algorithm now, how do we treat the first line relapsed CLS? For patients who are Binet AB and 0 to 2, who are asymptomatic, who have an inactive disease, we watch and wait. For patients who have an active disease and who have got RAI 3 or 4 stage or Binet C, and if the patient's TP53 is intact and IGHV is mutated, then we might treat with chemoimmunotherapy, FCR for younger patients, bendamustine rituximab for slightly older patients. However, for these patients also, glutathione inhibitors have been approved, and we can use them upfront. For patients with IGH unmuted status and EP53 intact, initial recommendation is to use glutathione kinase inhibitor. However, chemotherapy or bendamustine with rituximab may be used. For patients who have EP53 dysfunction, recommendation of using chemoimmunotherapy is very low down. In fact, can cause more clonal evolution. So the recommendation is to start BTKs upfront with venetoclax or without venetoclax. So for people who relapse, first time if they have received the chemoimmunotherapy, they progress after 3 years. TP53 IGH mutated, we can typically cross non-cross-reacting alkylators, and if the patient is IGH unmutated or there is a TP50 dysfunction, we to move to a glutathione kinase inhibitor. And if the patient has received ibrutinib in the first line and is intolerant to ibrutinib, then he or she must be shifted to a BCL2 inhibitor or a PI3K inhibitor or an alternative BTK. And if the patient is refractory, then he may be shifted to venetoclax with a PI3K inhibitor. If the patient has received a venetoclax-based monotherapy upfront and is refractory to it, then he may be started on an BTKI. So, CLL is not a single entity; it is various entities. So, a genetic profile is must. You must know the prognostic scoring before we start any patient on treatment. And in the BTKI era, we have to question whether we are prognosticating the patient correctly and whether the patient benefit more BTKIs. And with novel BTKIs coming in place, the role of conventional CIT also becomes questionable. However, combination of immunotherapy with the glutathione kinase inhibitor may probably give operation cure in the future.
Thank you, Dr. Rajat sir. The role of chemoimmunotherapy or the management of CLL has evolved from the chemotherapy combination regimens to pure immunotherapy regimens to finally to more selective BTK inhibitors. So thank you for taking us to the journey of role of CIT in management of CLL. Next we have Dr. Meet Kumar sir, who will be taking us through the role of acalabrutinib, a second generation BTKI in previously untreated and relapsed refractory CLL. And Dr. Meet Kumar sir is a consultant, a hematologist, a department of hemato-oncology and bone marrow transplantation with more than 15 years of experience, and from Fortis Memorial Research Institute, Gurgaon. Dr. Meet Kumar sir, it's a privilege to have you here, and over to you, sir.
Thank you so much. So is Dr. Aniket here?
Yes, sir.
So before starting the talk, can I just ask him 2 or 3 questions if there is 2 minutes time that is available to me?
Definitely, sir.
So Dr. Aniket, 3 questions. What is the prevalence according to you for the high risk CLL in clinical practice? That is one. Second thing, what is the mechanism of action of IGHV unmutated status for it to be a high risk disease? And third, what are the tests that you currently recommend to be done at CLL patient who is going to start the treatment? These 3 questions I need the answer from you.
Dr. Aniket, sir, if you're speaking, you're on mute.
I think we've lost Dr. Aniket, but he'll be back. I think for the panel discussion, we can shoot these 3 questions to him that time, Dr. Meet, if it's okay.
Sure, that's absolutely fine. So I'll just proceed with the presentation. Thank you, Dr. Rahul Sood, for the wonderful invitation and organizing this wonderful academic session this beautiful morning. And of course, as for making me a part of it, Shweta, Amrit, everyone is there. And the next slide, please. I'll not waste much time and proceed straight away to the presentation. So we have discussed many of times the role of the newer BTK inhibitors Dr. Rajat very beautifully mentioned and started sort of explained what is the role of chemoimmunotherapy. And that was the reason why I was trying to understand from Aniket, like what is the incidence of high risk. To me, it is around 20-25% of high disease. So that essentially leaves us with the chemoimmunotherapy in today's world. Depending on the age and other comorbidity status, it might be BR or FCR, whatever it is. We most of the times are not using FCR because of multiple issues that we all face. We are mostly resorting to BR. But having said that, once we start discussions with the patient, even in the low risk category, we have seen day in, day out that the patients usually prefer to go with a oral therapy for their CLL rather than going for injectable, maybe once in 3 weeks, once in 4 weeks chemoimmunotherapy. So that is the point I wanted to highlight, that yes, there is clear distinction between the treatments that are available as per the guidelines. Clinical practice might actually be slightly see, read, understand disease. We have discussed this. CLL is a disease of essentially the elderly, but as was told by the previous speakers as well, it usually happens in the Indian setting in kind of younger patients as well. Next slide, please. So the major issue with CLL is it has got a lot of comorbidities with it. Almost close to 40-45% of patients do have a significant comorbidities, including rheumatological, dyslipidemias, high blood pressure already. So there are molecules that we will be discussing subsequently that have an impact on the high blood pressure and cardiac comorbidities. But yes, these patients may harbor already these comorbidities to start with before even we embark on the journey of CLL treatment. Next slide, please. So this is what is the data for CLL. Dr. Rajat very justifiably explained to us that what is the role of chemoimmunotherapy, and that is perfectly agreed. But over the few years, last 5 to 7 years or so, the treatments for CLL have completely changed from high risk to low risk and to intermediate risk. The very interesting thing I learned to be default for asymptomatic. That is a point to be understood and interpreted in clinical practice. So having said that, these are the major trials that have been done so far that have established the role of the newer molecules in CLL, be it the ibrutinib, acalabrutinib, or the venetoclax-based regimens. Resonate 2, Illuminate, Elevate TN, and this trial of CLL14, all these have established the role of these newer molecules, and they have shown the significant progression-free survival and overall survival benefit over and above the conventional chemotherapy or chlorambucil-based regimens. Next slide, please. Next slide, please. Coming straight to the newest addition to the treatment armamentarium is probably acalabrutinib, that is available to us for quite some time now. And the advantage over the second generation BTK inhibitor, that is acalabrutinib, over the first generation BTK inhibitor, that is ibrutinib, is essentially its specificity and less side effects as compared to ibrutinib. That's the crux of what we'll be seeing, what we'll be understanding in the next 2 or 3 studies that have been published. But yes, this diagram is just showing that the off-target activity of acalabrutinib is significantly lesser as compared to ibrutinib. Next slide, please. So that's the first trial for the treatment of newly diagnosed CLL, treatment-naive CLL. And what is the data available for those patients of comparison with conventional chemotherapy with chlorambucil obinutuzumab combination with or without, as compared to acalabrutinib with or without obinutuzumab. So this is the trial that was published recently. It incorporated patients who were more than 65 years of age, who had untreated CLL and required treatment, who had a good performance status and had gotten adequate organ functions. The patients who were excluded from the study essentially involved those patients who had a previous treatment for CLL, whatever treatment they had received, they were not eligible to be included. And those patients who had required or was receiving anticoagulation with warfarin. We know that, and acalabrutinib, ibrutinib, BTK inhibitors have got an interaction on the increased bleeding tendencies. So those patients who were already on blood thinners, they were essentially excluded from this study, especially during those patients who had received within the last 7 days of the starting of the study drug. So the patients were randomized to the 3 study groups. They were randomized to either obinutuzumab with chlorambucil, acalabrutinib with obinutuzumab, or acalabrutinib monotherapy. as we can see, the number of patients were equally divided amongst the three groups, and there was a comprehensive study of close to 500 plus patients. So the primary endpoint in this study was assessment of progression-free survival and overall response. Secondary endpoints were again overall response, overall survival, and time to the next treatment. Next slide, please. So this is a baseline of the three cohorts that were evaluated. In the three cohorts, the baseline characteristics of all the patients were more or less similar, including the molecular genetic studies of these patients, be it 17p, be it unmutated IGHV, the high risk and the lower risk were more or less comparable in the three cohorts. Next slide, please. So this is what came out. What I can say is just skip to the next slide. We can see in the Kaplan-Meier that's on the next page, and that shows us with ACAL really better as compared to chlorambucil-based combinations. So if you see the lowest curve, that's a grayish curve that stands as 25%. That's the curve for chlorambucil obinutuzumab arm in terms of progression-free survival at 48 months, that is 4 years. And when you see and when you compare it with ACAL-based combinations, even if the ACAL ibrutinib was there, that progression-free survival at 4 years was 87%. Also, so we can clearly say that the combination of obinutuzumab chlorambucil is way inferior to ACAL-based combination. We cannot say that obin is working significantly or contributing significantly to the improvements, because without obin also that there's just a dip of the progression-free survival by 10% as compared to 87 versus 78%. Next slide, please. So whether this holds true for the high-risk disease, so that's the whole contention that we're talking about, the percentage of high-risk patients that we see in those category of patients, what is the best molecule for us to have, and in the sense that whether these newer molecules work on them, and that is the beauty that these we have a high risk in terms of whether it's 17p unmutated IGHV, or even if like as I understood from Dr. Aniket's talk, that whether it's a Notch1 mutation, I wanted to ask him this also, whether Notch1 mutation is also regularly done, or how can it be done, whether we don't need to do an NGS sampling for all the patients to identify these high risk diseases, so that we are able to justifiably say that these are the molecules that the patient should receive. So talking about ACAL ibrutinib in high risk disease, 17p deleted, the solid lines are for the 17p deleted for the three cohorts, ACAL obin, ACAL mono versus obin with chlorambucil, and we can very clearly see the graph separating again in the favor of ACAL based combinations, both for 17p deleted as well as 17p undeleted, or TP53 mutated and TP53 unmutated. So the curves are definitely separating out, and that holds true to say that ACAL based combinations do have a significant impact and benefit in terms of outcomes for patients with high risk disease in terms of 17. Next slide, please. What holds true for IGHV unmutated? This can be seen very well in this curve, in this Kaplan-Meier. Again, the graphs are separating in the favor of ACAL based combination, as we can see. I think there is some issue. The graphs are not showing here the solid lines, only the dotted lines. The graph also has solid lines. I think there is some technical issue with that. But what I can tell is the original Kaplan-Meier that was there, that had shown the graphs to be separating in favor of ACAL based combinations, even if the patients were either IGHV unmutated or mutated, the responses were in favor of ACAL based combinations. Next slide, please. Yeah, now it has come. So now it has come. Okay, great. Next slide, please. So this holds true for all the high-risk parameters that we can assess, whether it's age, whether it's gender, whether it's ripe stage, whether it's performance status, whether it's bulk disease or not. All these parameters hold true. And as Dr. Aniket was saying, that trisomy 12 with Notch1 has got a higher incidence of Richter transformation. Then in those particular cases, whether it will be justifiable to add the BTK inhibitors or BCL2 inhibitors, that's a question of debate. Next slide, please. So again, the same thing holds true. Next slide. Yeah. So when we talk about the adverse event profile, we all have used the chemoimmunotherapy-based regimens. Dr. Rajat had already explained to us the side effect profile of those. We are already aware of most of the molecules. We all have used the newer molecules as well, venetoclax in one disease or the other, and BTK inhibitors, at least ibrutinib in one disease or the other. We have all used these molecules, and we know more or less that what are the side effects profiles and how safe, relatively safe it is to give these molecules as compared to the chemoimmunotherapy. The important, interesting point here is the BTK inhibitors and BCL2 inhibitors, that might be a contradictory statement, but what my personal experience is, there is a definite increase in risk of infectious complications. But yes, the much more hyped complications like the cardiac events and the bleeding diathesis that is reported and hyped much more with BTK inhibitors. At least personally, I've seen only in one patient, I can say, of maybe like significant number of patients that we have, when we take non-bleeding diathesis related disorders. If we compare, when we compare the three cohorts, there is slightly higher incidence of headaches and arthralgias and upper respiratory tract infections in the ACAL based combinations as compared to chlorambucil based combinations. Next slide, please. So this is what I was talking about. So these are the major and much highlighted complications or side effects of the BTK inhibitors that are available to us. The selected cardiovascular adverse events we see, the atrial fibrillation, flutter, ventricular arrhythmias, and hypertension, is, as per this bar diagram also, it says that it's significantly higher in the ACAL based combination as compared to UBIN. But when we see and we try to sort of dissect this bar diagram, in the lower half of each of the graphs, if you see the darker shaded columns, what they are the actual grade 3 or more adverse events of that category of clinical relevance. Maybe minor grade adverse events, grade 1, grade 2, are manageable with minor dose reductions, but these are the events of clinical relevance, as in we need dose interruptions or things like that. And these are these sort of side effects, grade 3 adverse events. If we compare, there is not much difference between the ACAL and non-ACAL based combination. So this is what I want to highlight, that even if it is chlorambucil based, ACAL based, the grade 3 adverse events of cardiovascular events is not significantly different between the two cohorts. Next slide, please. So yes, so if we compare the three cohorts in terms of either dose reductions or dose discontinuations, dose discontinuations Hello.
Yeah, Dr. Meet, we lost you for some time in between. Now we
Am I
can
audible
see
now?
you. Yeah, now you're visible as well as audible. Please go ahead.
Okay. Thank you so much. Thank you so much. So I'll just proceed from here. So, like, what is the significance? Do these patients achieve on patients, high risk patients or low risk patients, do they achieve an MRD negative status? MRD is coming into a big way in almost all hematological malignancies that we are now seeing. That holds true for CLL because it has shown to have an impact on the progression-free survival. And yes, if you see the red columns, these are the patients who have achieved the MRD negative status in the three cohorts. And that is, sorry, green columns, if you see, they are the MRD negative statuses that have been achieved in the three cohorts. And that shows that again, this goes in favor of ACAL Gazyva combination as compared to non-Gazyva based combinations. So that is a significant point here. Again, this needs to be evaluated in much more detail, that the best MRD negativity is achieved more with patients who receive ACAL obinutuzumab combinations. So coming to the next study, that is ASCENT trial for relapsed refractory patients, that compared the much hyped BTK inhibitors that included the BTK monoimmunotherapy compared to either bendamustine rituximab or idelalisib rituximab. rituximab combination. I can go to the next slide where the Kaplan-Meier itself speak for themselves. And that showed clearly that patients who had relapsed refractory disease, the upper curve is for ACAL monotherapy versus rituximab based with the rituximab combination either with idelalisib or bendamustine. That showed that the curves are significantly splitting out in favor of ACAL based combination, ACAL based treatment for this relapsed refractory setting. Next slide, please. So again, this study that compared ibrutinib with acalabrutinib in a phase 3 non-inferiority trial, close to more than 500 patients enrolled, ACAL at 100 milligram twice daily till disease progression versus ibrutinib 420 milligrams. Primary endpoint was non-inferiority assessment in terms of progression-free survival, and these were the eligibility criteria for the study. Next slide, please. So some interesting facts came up here. The baseline characteristics were again same for the two cohorts. Next slide. No difference in the progression-free survival at more than 4 years. No statistical difference between the two cohorts, whether it was ACAL, whether it is ibrutinib. There is no difference in outcomes. Next slide, please. So this is what was important. The incidences of cardiac adverse events in the two cohorts were slightly better in favor of acalabrutinib as compared to ibrutinib. This is understandable because of the lesser off-target effect is treatments, and this is very visible in this bar diagram. 9% versus 16% of any grade atrial fibrillation in ACAL versus ibrutinib-based arms. Next slide, please. So whether there was any difference in terms of increased infections or incidences of registered transformation or an impact on overall survival between the two cohorts? No, there was no difference in terms of the infections because essentially these are the BTK inhibitors, and we should not expect a major differences. Yes, there are some additional off-target impacts of ibrutinib as compared to ACAL, and we should expect that infectious complications might be slightly higher in the ibrutinib arm, but that is not the case, and there was no significant difference between the two in these parameters. Next slide, please. So the adverse events again were more or less comparable, except for the fact that the adverse events of clinical interest, that is the cardiac events and the bleeding diathesis, were slightly lesser in the ACAL arm as compared to the in the ibrutinib arm, and that was manifested in the discontinuation rates. The discontinuation rates of ACAL ibrutinib was 15% versus 22% in the ibrutinib arm, and that was essentially due to the intolerance and the side effects profiles of these two molecules. Next slide, please. So this is again visible in this bar diagram as well. The safety profile of the two molecules were in favor of ACAL. The blue diagrams are the ibrutinib, and the pink diagrams are for the ACAL ibrutinib. And again, if we compare at the bottom of each of these bar diagrams, the darker shaded ones are the grade 3 adverse events seen with each of these molecules, and that favors, I can say they are more or less comparable, except the hypertension arm. I'll say more or less for the hemorrhage and the arrhythmias aspect, the both of them are comparable. But yes, hypertension is slightly more in the ibrutinib arm, significantly higher in the ibrutinib arm as compared to the ACAL arm. Next slide, please. I think this we have discussed previously. Next slide. Yeah. So why should I be concerned about low-grade atrial fibrillation? Again, the data showed, as we had discussed previously, 16% versus 9% was the rate of cardiac events with ibrutinib versus acalabrutinib, and that definitely was supported in multiple trials, not only this trial. The non-comparative trials also had suggested the similar data for ibrutinib, and when it was compared randomized against acalabrutinib in this study, that definitely showed up in the sense of positive impact of ACAL over ibrutinib. Next slide, please. I think we have discussed this. Next slide. Next slide. So the overall cumulative incidence of ACAL-based cardiac events is to the tune of 5%, and that includes all grade 3 adverse events cardiac. Of this, the atrial fibrillation happened in 1% of the patients and atrial flutter in another 1% of the patients. So this is not a randomized, this is not analysis, pooled analysis of ACAL, and that is what is the incidence of ACAL ablative. Next slide, please. Yeah. So the time to onset, this is an important thing. So when we compare the time to onset with ibrutinib versus ACAL ablative arms, the time to onset for atrial fibrillation is close to 17 months for ACAL ablative versus 6 months for hypertension. So this is an important take-home thing for us, that the hypertension usually starts at 6 months from the start of treatment, while AF usually develops. This I'm specifically talking about those patients who did not have a pre-existing comorbidity cardiac illness. For those patients, at least, the hypertension starts at 6 months, and the atrial fibrillation side effect, even if it is because of the BTK inhibitors, usually starts at 17 months. If we are closely monitoring the cardiac complications over time, we may be able to pick up early the cardiac complications that are happening to these patients, in those patients who do not have a pre-existing cardiac comorbidities, and that might be helpful in terms of preventing any progression of the cardiac illness. Next slide, please. Next slide, please. So yeah, this is just highlighting that ibrutinib intolerant patients, because of whatever reason, whether it's because of diarrhea, whether it's because of rash, almost 30% of the patients of ibrutinib intolerant might tolerate acalabrutinib better as compared to no BTK inhibitors. About the dose adjustments, depending on the cytopenias that are caused by these molecules, we can dose adjust. Next slide. So headaches is a symptom. I have used ACAL in only one patient. That patient at least did not complain of headaches. But yes, the reported literature suggests that there is grade 1 to 2 headaches that are reported in 97% of the patients, that usually responds after either discontinuation or dose reduction of ACAL. Next slide. So that's an interesting thing. That what is the difference? Like the patients with a pre-existing cardiac comorbidity, maybe AF, who are on anticoagulants, and what is the challenge for them to be started on atrial fibrillation? The data suggests with acalabrutinib, the data suggests of 3.6% incidence of ACAL bleeding on patients who are on anticoagulants, as compared to 2.7% on ACAL patients who are not on blood thinners. So that is the difference. Of course, that is a very significant number. So in personal capacity, at least I try to avoid any BTK inhibitors in patients who are on anticoagulants. But that is a debate. That is a question for open debate, that when we can use and what are the comorbidities when we can address and try to use BTK inhibitors, even in those patients who are sort of at risk for developing either cardiac comorbidities or bleeding dialysis because of the underlying cardiac illness. Next slide, please. So I think, yeah, so we have come to an end. I think I can hand over the mic to Dr. Rahul once again.
Thank you, Dr. Meet, for a lovely presentation. A lot of questions are there, which I'll again they take up in the when I moderate the session on panel, and I love you to be a part of the panel that time. So Akash, over to you and the next speaker, please.
Thank you, sir. Thank you, Dr. Meet, sir, again for that wonderful presentation. Next up, we have Dr. Amit Upadhyay, sir, who will be taking us through how to manage MCL at first relapse when we look at from an Indian context. Now, Dr. Amit Upadhyay, sir, is a senior consultant hematology from QRG Super Specialty Hospital, Faridabad, Haryana. Dr. Amit, sir, it is I mean, we would love to hear from you on how to manage MCL and in first relapse setting. Hello, am I Dr. Rahul, sir? Am I audible?
Yeah, Akash, you're audible. Subi, could you find out whether Dr. Amit has joined or is having some problems in logging in?
Just give me 2 minutes, sir.
Yep. Dr. Aniket, you there? Surbi, you'll have to also remind Dr. Aniket that he's a part of the panel discussion, and there are 3 pending questions
Yes,
from
sir.
Dr.
Yes,
Meet
sir.
also
Okay.
for him. So Dr. Meet, a very quick question, in case you permit me. So, am I audible, Akash?
Yes, sir. You are.
I
think Dr.
we-
Meet sir has some connectivity issues, I guess.
Right. Fine. We'll wait for another 2-3 minutes. Surbi,
I'm so sorry. I'm so sorry. I'm
सर
so sorry.
एक्चुअली कुछ कनेक्टिविटी इश्यूज हैं सर के. मैं एक बार बात कर रही हूँ उनसे. मैं बात करके
Okay.
Am I
just give me
audible?
2 minutes.
Yes, sir. Yes, Meet
yes.
sir.
I'm so sorry. I just missed it. Please, sir.
Dr. Meet, lovely. I wanted to know your experience with that patient on acalabrutinib. See, we are all learning from each other, I think, when it comes to the new BTK. So, how did you go forward with that patient? Would love to know from you, please.
So what I'll share, Dr. Rahul, the thing was this patient essentially was from Bangladesh, and what happened to him was he was diagnosed to have a high risk CLL with deletion 17p. He traveled all the way, like the diagnosis could not be made as essentially it was an SLL to begin with, and in that in the lymph node biopsy we could pick up the disease, and ultimately he was counseled to start on a BTK inhibitor. Initially, he was unwilling to go for acalabrutinib. He was started on ibrutinib at 420 milligrams. He continued that for almost 3.5 months. But he went back at that point of time. He went back to Bangladesh and he was continuing the treatment. At the end of maybe around 3.5 months, he called me up saying that he has developed some ecchymotic patches over the skin. So for that, I asked for the photographs. We evaluated him in detail. The coagulopathy program, the coagulogram we did, the prothrombin time, fibrinogen, APTT, D-dimer, everything we did, and all that was negative. So at that point of time, I asked him to come back to India and sort of be discussed at length, and we had a detailed discussion about so what are the options now we have, considering the fact that he was 17p deleted. So we discussed venetoclax and we discussed about acalabrutinib. So he was rather comfortable with going ahead with acalabrutinib. He started acalabrutinib. He took that for 6 months. After which he came back again. He has 2 visits after that. The last visit was 1 month back, and the visit before that was close to 4 months back. And that time only we had done the bone marrow and everything. We had done the PET scan, and he was in the remission. That was a metabolic response as well as just to document. This was document. We routinely, I'm not trying for a documentation purpose. We did a PET scan and a marrow assessment at that point of time, 4 months back. At that time, he was in remission. He came back again last month. At that point of time, also, he was in clinical remission. We did not do a marrow or a PET at that point, but he was in a complete hematological response and without any symptoms. He has been off treatment till the last 4 months. So now he's off treatment for last 4 months, and we can say that at so far at least I'm happy that he is maintaining a disease remission status. So that's what the success story about that patient is.
Right. Wonderful to know about this. And I think it's a great journey for this patient. And I think he should continue to do well. But tell me, Dr. Meet, do you contemplate adding us anti-CD20 like a rituximab with acalabrutinib in any of your patients? Or is there any subset you think where we can add? Though I know the data, obviously.
See, what I'll say, Dr. Rahul, is 2 things. One is the only limitation that at least I feel personally with the BTK inhibitors is the time defined. It's not
Right.
time defined therapy. So that's a major limitation. If we talk, does wonders for these patients of high risk CLL, but at the same time, unlimited defined, no, without any timelines, that's a difficult call. So there is some data that is cropping up of adding a second agent of like ibrutinib or acalabrutinib to either venetoclax or rituximab, just to make it a time-defined treatment. And if that is achieved, that will be a really welcome step, and that will be a really remarkable thing to happen. As in, like, we'll be able to tell patients that, okay, you have to take 6 months, 1 year, 2 years therapy for the disease to get controlled, and after that you can go off therapy. So the current limitation can possibly addressed by the question that possibly you're raising.
Thank you so much, Dr. Meet. Thank you.
Thank you so much.
Sir, can हम लोग इतने आगे बढ़ सकते हैं? Panel discussion start कर दें? Maybe
Yes.
there's some issues with Dr. Amit.
So
After
the
panel discussion,
right. Okay, fine. We can start the panel discussion, but I can see Dr. Meet is definitely there in the panel. But what about Dr. Aniket, Dr. Amit, and Dr. Rajat? Are they available?
sir, Dr. Rajat left.
Okay.
And Dr. Amit sir will not able to join because उनका कुछ issue हो रहा network का. He will join in some minutes.
Dr. Aniket?
And Dr. Aniket is not replying. He
All
joined.
right.
He's on call, but I don't know.
Okay, fine. So let me start projecting my slide. So it's, I think, one-to-one panel discussion with Dr. Meet itself. So Dr. Meet, you're the only one. So I'll just share my slides then, right? Right. Okay. I think visible. Slides are visible. Akash,
Yes,
slides
sir.
are
Yes, sir.
visible.
Yes, sir.
Yes, sir.
Yes, sir.
Yeah. Okay, so I start with this CLL MCL case-based panel discussion. So let's go forward. My first case is a 70-year-old patient with extensive bulky neck nodes, hemoglobin of 10, a TLC count of 46,000, and a reduced platelet count. The flow cytometry confirmed a CLL diagnosis. The FISH showed a trisomy 12. Patient had comorbidities of hypertension, dyslipidemia, which is very apparent in our population of 70 and above, and also had to add to this, had a history of CABG. So questions for the panelists. I have only Dr. Meet right now. Let me know, Surbi, if the other panelists join. So how would you manage this patient considering the comorbidities, and how would you divide the patient's profile into those eligible for chemoimmunotherapy or the new BTK inhibitors? So Dr. Meet, to you only, all three. Hello.
Yes, sir, you are audible, sir.
Yep, but I think my panelists are not there, I think. None of them.
Meet sir is there, sir. He's on call.
Yeah. Dr. Meet, are you there? So we just have a look here, please.
Yeah, just give sir, मैं call करती हूँ, एक मिनट दीजिए.
Okay. Akash, I think I'll continue this because of the paucity of time, I think. Correct?
Yes, sir. I think, yeah. We'll see.
So I think what we have here is a 70-year-old gentleman who has lymphadenopathy, like I showed you, and had a high TLC count. He had a diagnosed CLL, but he had problems of hypertension, dyslipidemia, and trisomy 12 plus. So these were the questions which were there, and how do we go about it? See, in my practice, what do? Is I start my patients definitely on a chemoimmunotherapeutic agent, because the patient does not have any risk factors or the high risk genetics at that time. So that is what it was done. The patient was started on bendamustine and rituximab combination. However, he visited 1 year later with a clinical significantly meaningful improvement. So we were very happy with this patient. But in the meantime, he visited another hematologist who got a FISH done, and he was found to have a deletion of the 17p. So that means he had a high risk factor. So what do we do at this end? If any of the panelists has joined, please take up, otherwise I'll continue. Surbhi, anything?
Sir, everyone is busy.
All right.
Dr. Meet is on call, actually.
Okay.
So he will join in a few minutes.
Just let me know when he joins. So I'll continue
Yeah,
in
sure,
the meantime. So how do I manage this patient now? Will I start the patient on a Bruton tyrosine kinase inhibitor immediately, or wait and watch? And what will be our treatment of choice if the patient with CLL with all these risk factors? So what do I do? Will I start BTK inhibitors immediately? No, that is not what I will do. I will definitely continue the winning combination that the patient has, that is the chemoimmunotherapeutic agents. And if the patient has already finished his treatment, the wait and watch policy is the best way to go forward. However, again, a school of thought is there. The patient has a del17p TP53 mutation. So this patient will progress very, very rapidly. An individual who can be closely followed up with either imaging, blood tests. Yeah, I can see Meet joining. Hi. So this patient, we will be also right in continuing the treatment that we have. That is, we can continue the BCR inhibitors. So hi Meet, you're back. I'll quickly go to the second case because the first case I've almost discussed. So this is, now we come to the second case. Dr. Meet, this is for you. Hello. Is Dr. Meet there?
Yes, sir.
Yes, Dr. Rahul, I'm so sorry.
Right. So Dr. Meet, the first case I discussed as a moderator and a panelist myself. So let's go to the second case.
I'm so sorry for that.
So nice to have company in the panel discussion then. So now this is a relapsed refractory CLL. So the 74-year-old female, IGHV status unknown, 3 cycles of bendamustine rituximab, discontinued due to toxicities and discharged, presented again 3 months later with B symptoms. TLC was high, platelet was low, and hemoglobin also was low. So cytopenias with raised TLC count. So these are your questions, Dr. Meet. So what would be your management, and what will be your approach?
So do we know the repeat FISH testing at this point of time, at the time of disease progression?
Not done.
It was not
done.
So, yeah, so I think still what we should be saying is that this is, since there is a relapsed disease or it's a progressive disease, whatever we may call it, there is good chances that she might be harboring some high-risk mutation.
Okay.
In her genetic profile for CLL, for 3 cycles, and after that she went off therapy for whatever reasons. That probably challenging at 74 years might not be a very good option. The option that essentially we are left with is to go for one of these newer molecules. Again, if you say rituximab-based therapy or rituximab monotherapy-based therapy, that could have been an option at the first go, but this patient has relapsed after 3 cycles of rituximab. That might not be a very good option. So I might probably I would consider either of the 2 options depending on the discussion with the patients and the family. What is best for her in terms of a BTK inhibitor versus a BCL2 inhibitor, and that is the point of discussion that I will probably go on to.
Right. I think fair enough, because these are the 2 options we have. And this is the data I think you also showed, and I think even Rajat also showed the Resonate and the Murano trial, which was there, which showed the benefit of the BTKs versus the anti-CD20 or the bendamustine rituximab, which was there. And this is the Ascent trial. This also you showed. So point absolutely taken. Even with and without the deletion, there is the benefit which is there, and the acalabrutinib is the one which scores in both the subset. So your question again, the additional diagnostic test that you recommend, I actually had kept it for Aniket, but Aniket is not able to join, and the MRD in India, and how do you decide between the front line and the second line treatment? I know you discussed it at length in your presentation, but a line each.
So I would say, like, I will say the test that I do is a fish for CLL and IGHV mutation status. From the understand from the panel and Syrian people like you and probably Aniket would have added that what is your practice? Do you do NGS testing for all patients to identify a TP53 mutated status or to identify a NOTCH status and things like that? Do you routinely do that, or you are also sticking to FISH for CLL that includes a deletion 17p but nothing else, no mutation that is identifiable on a FISH we know, and IGHV mutation status? Do you do anything else other than these things?
So we do the FISH definitely, and now we've started doing the TP53. We are not doing the notch and the others. We're not asking for that.
IGHV you are doing?
Pardon me? Yes, we are doing IGHV also. We are doing an NGS. First, we are doing
IGHV you are doing?
Yes, we are doing IGHV. We started doing IGHV because IGHV is now also dictating our treatment apart from what we get from the FISH report. So I think it is important. We do not wait for the reports to come. The FISH. We start on the basis of probably the FISH, which is the earliest that we get, and we start our treatment. And but MRD evaluation practices in India, are you following that,
no.
Dr. Meet?
For CLL, no.
No, absolutely, we are not. We are also not following MRD, and I don't know whether it will see the light of day in India as it has seen in the other acute leukemias. So frontline and second line treatment with ibrutinib and acalabrutinib in a CLL patients, is it still ibrutinib?
I'll say the patient is the one who is to decide it. Depending on, we can tell the patient, we can counsel the patient, we can discuss the pros and the cons for each of the molecules and on each of the options that are available to us. But essentially, it boils down to the patients, the families, and the pocket size that ultimately decides what is the best treatment for them.
Absolutely.
I believe same is in your setting as well.
Absolutely, ditto. Actually, majority will go on ibrutinib. We wait for complications to ibrutinib or probably something else like that. And yes, generic ones that are there. So third case, relapsed refractory CLL again, now with the flavor, the atrial fibrillation, which is there. And IGHV unmutated, DEL 17, diabetic, previous history of AF, TLC of 45,000, and palpable spleen and cervical lymphadenopathy. So management, Dr. Meet.
I will prefer to use, I just lost the last thing. So like how is she controlled? So AF happened how many years back?
So previous history of AF, that's just a previous history. She's probably in a control rhythm with the treatment that is going on.
IGHV unmutated and 17p deleted.
Yeah, so high risk patient.
We don't know how old the AF was and what is the present status.
I'll have to hypothetically take it because I don't have the information right now. So
whether she's on anticoagulants or not, that.
Yes. So these information I do not have. So we can probably say that patient is on anticoagulation on acetrom, and the rate is controlled, and maybe she has got a history of say 10 years of AF.
Again, I'll say my first preference will be to go for a BCL2 inhibitor than a BTK inhibitor. And of course, maybe it may be discussed as I was showing in the last slide. There is also not much difference. So yes, so one contention can be like if the patient is on double anticoagulants, maybe there is a strict no for BTK inhibitor. But yes, if the patient is on a cardiologist and if he's willing and is sort of comfortable to withhold the double anticoagulation, which usually is not the case, in that case only we should consider to try BTK inhibitors.
So which BTK inhibitor for this patient, Dr.
Either again, that depends on the patient's.
Again, right. So nothing much to choose. But there was data of a higher AF with the acalabrutinib, I think. That is what you showed, or was it the same?
Yeah. So in that sense, yes. So again, we'll discuss. We'll give the options, and if we are moving towards BTK inhibitor, then yes, of course, scientifically, definitely, second generation BTK inhibitor would be preferable. The ACAL would be preferable.
Okay, right. Single agent without rituximab, obviously, right.
I still have to see the data of BTK inhibitors with CD20 inhibitors.
Correct. Yes. There is data of Obin you showed, right? With ibrutinib and Obin data you showed, but I think it's
So
still...
Obin with ACAL data is there, but
Yeah.
as I told, there is not much difference in the outcomes between ACAL Obin versus ACAL.
Right. So, Dr. Meet, I think infections are a major concern when you give BTK inhibitors. So, what do you do in such patients? You did show in your slides.
So yes,
do you give prophylaxis?
At least I usually do not. I'm not very sure of the recommendation, but I do not.
I think there is no data of any prophylaxis which is there. But yes, there is some data coming into immunosuppressed individuals, like even diabetes, CKDs, where quinolones have been used, and even Ceptran has been used. But yes, data is not there. So this is what it is. Now coming to our last case on MCL, which is there. We missed Dr. Amit's presentation, but anyway, we'll have a panel discussion. So this is the MCL patient who came with cervical lymph node stage 4, ECOG stage 1, blood counts of 8,500, bone marrow aspiration showed involvement, and the typical lymphoid, the immunophenotypic picture of MCL. 30 was the Ki67 and an intermediate MIPI score. Patient was treated with R-CHOP, and the patient received high dose therapy thereafter, after the patient had achieved CR, the patient received high dose therapy with autologous stem cell and achieved a CR thereafter, which is the standard treatment in any mantle cell. Now, the 65-year-old man with pleomorphic histocytic MCL, approximately 2 years later, the patient showed a relapse with elevated LDH and a relapse in the bone marrow. A good match for this patient could not be identified. So obviously, he was not a candidate again for an allogeneic stem cell transplant. So what do you do for such a patient, Dr. Meet? Now it's MCL.
The patient relapsed after how much time of autologous transplant?
2 years.
2 years later, he has relapsed. I think definitely
yes.
At this age, he has got an aggressive disease. Despite the best treatment, this patient is just relapsing after 2 years at the age of 67, 68 years.
Correct.
He is definitely not a candidate for any high dose therapy. So the thing that probably I would resort to is, again, going towards chemoimmunotherapy at present.
Right.
I've not gone through in detail about the data of BTK inhibitors in this cohort, but I've heard that the data is encouraging, but I've not in detail gone through that. I think you are the better person who can educate us on this. And but yes, I'll probably go for a second salvage chemoimmunotherapy for this patient, and depending on the performance status and things like that, maybe consider for a consolidation with one of the molecules, lenalidomide, bortezomib. These molecules are definitely there, and they are helpful in sort of even venetoclax. So these are the molecules that have good data, BTK inhibitors. So one of these molecules will have to be resorted to.
Yeah, so bang on. I think the duration after which the patient has relapsed, the performance status, and the patient preference is the most important. The performance status guides us, and this is what is our protocol, and that is what we follow. We know a person who has relapsed after 2 years is probably having a decent biology of the disease. I won't say a good biology disease or a very poor biology disease, but a decent biology of the disease. So the patient can be taken up for another transplant, but in this patient, we did not have a match. So majority of our treatment is based on the chemoimmunotherapy that you said. So first is to bring down the load of the disease by giving chemoimmunotherapy, and then maintain it with either lenalidomide or use the novel molecules that you said. So absolutely point taken, and that is what the NCCN also says. A gamut of treatments are available, gamut of things are available. Everything depends on the performance status of the patient, the physician's choice, and the patient's preference. So this is how you go forward. And I think the tumor board plays a very, very important role in this patient, and the counseling of the patient does maintain. But what is important to know, Dr. Meet, is the maintenance rituximab has a role in such patients. And as you can see, this has been continued 8 weekly for a period of 3 years. So what is your
this
take?
Data?
Yeah, please go ahead.
Is this data post salvage or post for relapsed lymphoma? Is that not so?
Yeah. So this is the data which is there. This I'm showing you after the patient has relapsed.
Achha,
The
after
options
the
which are there. So you go for aggressive therapy, either these salvage regimes or the less aggressive therapies, and consolidate with either autologous stem cell transplant, and then you maintain this patient. In fact, there is a role of a second transplant also, which is there in the mantle cell lymphoma. So what they say is he can go for another autologous stem cell transplant. So something like you do in myelomas, and so there is that. Like I said, the patient needs to be individualized and seen, right? So what are the ideal time for BTKs in mantle cell lymphomas? What is the ideal time for regimes to start for these patients who have relapsed following ASCT? So I think there is no clear-cut answer. Dr. Meet, what about you? What do you think?
I think you're the better person to educate on this.
Yeah. So we are the lazy oncologists and the lazy hematologists that I am. So we try to give the tablet as early as possible. Wherever the patient relapses, we try to give the BTK inhibitors. In fact, many times we get mantle cell lymphomas who come in a very, very bad state. That means they will have thrombocytopenia. They will not be even fit for cytotoxic chemotherapy. These are the patients where we've even tried ibrutinib upfront itself. But when it comes to relapsed refractory setting of MCL, the drug to go forward for us is the ibrutinib or the acalabrutinib now, which is there. So as soon as the patient relapses, that is the way to go forward. So even those individuals who have relapsed after transplant, we go ahead and give them ibrutinib. So that is what is our take, and I think that is what the data also says, that now it is the treatment of choice for relapsed refractory MCLs. In fact, I had few patients who refused a transplant, and these patients, I had to keep them on ibrutinib for some period of time, and they came after 8 months or 10 months saying that, can we get a transplant now done? And when I checked these patients were in complete remission with ibrutinib. So what can I tell these patients? So
single agent ibrutinib, is it?
Single agent ibrutinib. No, in this patient, I continued rituximab. In fact, I continued rituximab in this patient. That's why I asked you this question, because we keep doing it for our DLBCLs, our high-risk lymphomas. We started this maintenance rituximab every 3 monthly for almost 2 years. And they've done extremely well with the maintenance. So I don't know. In our solid tumors, there is a role of definite maintenance in all our solid tumors. And somehow I have started extrapolating it into lymphomas and mantle cell lymphomas. I know data is not there, but people are doing well. So something to share from my end, which is there.
Absolutely. That is a very valid point, Dr. Rahul.
Yes, and rituximab is a very safe drug. It's a very safe drug. Our nephrologists are using, even our rheumatologists are using left and right, and this used to be our forte always. So once in 3 months, if the patient, in fact, I had a lymphoma who had a bone lymphoma. He comes every 3 months for a rituximab, and he comes for a zoledronic acid, doing very well. I don't know when to stop it, but almost 2.5 years, he is in remission. And when he came, there was only few areas in the body where the disease was not there. He had nodal, extra nodal, everywhere he had. So, just a food of thought, and that is what, these are the studies which are going on ibrutinib and all. And the discontinuation rates of ibrutinib And these are the problems that we get with. So last, before we pack up for lunch, another MCL MIPI score of 5.7 with lymphadenopathy, and initially started on the standard BR, had comorbidities of diabetes, hypertension, CVA, responded post 6 cycles. And these are the white blood counts as well as the platelets. So decent. So relapsed after 5 years. Now this is 5 years, Dr. Meeth, a different difference which was there. No AD adverse effect. So I don't know whether this patient was, followed by transplant. The patient was transplanted. So he relapsed after 5 years of transplant with subcutaneous nodules. And again, positive for the mantle cell lymphoma. Started on ibrutinib, must be somebody like me only who started him. So 420 milligrams. And after 2 months of starting ibrutinib, the patient developed tachycardia, breathlessness, and had AF. Hence, ibrutinib was withheld. And post 3 weeks, there was reappearance of the nodes. So what do we do? These are the options we have. So bortezomib with rituximab.
What I'll say, Dr. Rahul, so whenever there is a new case of at least mental, what I try to do in each patient is to know the KI index.
Right.
KI index is a very good marker because there are patients. So I believe mental is the only disease that can have a KI index 10% as well as 90% variation of KI, just implicating that the proliferation of the disease can be so variable in this disease. So if there is, what my personal perception is, that if there is a low KI disease, probably it's not that aggressive, and non-chemotherapy based regimens can be quite useful. That's what my personal perception is. I still have to see the data. But if it is a high KI disease, then without chemoimmunotherapy or chemotherapy, we might not be able to kill the disease or control the disease, at least to get into some sort of remission first. So what I would say, if it is a low KI disease, maybe straight away going to the
Yeah, Dr. Meeth, and we lost your audio.
Hello?
Yeah, you're back. Yeah.
Yeah, so I was just saying that if it is a low KI disease, maybe one of these newer molecules, but if it is a high KI disease, I might consider to give at least some chemotherapy, maybe bendamustine alone, a repeat of bendamustine, since this patient has relapsed after 5 years. Maybe a single agent bendamustine with or without rituximab, something of that sort, if that's a high KI disease.
I totally agree with you. And I think I was doing almost the same thing, because we know that the mantle cell lymphoma has subvariants. It has the classical, it has the leukemic, it has the histiocytic, it has the small cell, and it has the plasmacytic. And all of them have a different behavior. And the only marker which we have, in the absence of a trained pathologist who can differentiate it under the microscope, is the Ki67. And we can really use that as a surrogate marker to manage our treatment. In case we find that the Ki67 is low, bang on you, like you said, we can go for. Otherwise, if it is an aggressive disease, then I think the new kid on the block is there, the CAR T cells and all are there. So that is the way to go forward. So can BTK inhibitors be used as a bridging therapy for SCT? I have done in one patient, which I was talking to you about. And can it be used as a bridging therapy? I think we can obviously customize this. When rather than the wait and watch policy, we can definitely keep the patient on BTK inhibitors. So that is there. And this is the data regarding the CAR T cells, and it's there all over, which is there. However, in India, I know the CAR T cell will see the light of the day in probably the next 10 years, not before that. So I've already asked you this question regarding acalabrutinib and ibrutinib, so you answered it very, very well. So the only thing is the response to acalabrutinib when it comes to OR, or CR, or even the PFS is superior to ibrutinib. So something to look forward to and to discuss with our patients when they come. Yes, the cost is a problem. This is the NCCN guidelines. All these molecules, the BTKs, the BCL2, all are available, and the transplant still remains important, is the way to go forward still, even if after the second line consolidation. So that's all from my end, and I would like to thank Dr. Meeth specially for holding the baton or starting like they say in the IPL, to carrying on for the entire 20 overs and seeing the team through. He spoke like an international speaker, and we used him like an international speaker. So nice of you to be so big sport for this. And it was a wonderful discussion with you. I learned a lot. I would also
I think it was a mutual discussion. The two of us, the two tigers for today probably, and that
Right.
the feeding was absolutely by AstraZeneca. But I would say
Right.
it was a wonderful discussion to have today. And of course, I have learned a lot of things. Mantle cell, at least I was not. Of course, we see it quite not very commonly, but yes, whenever we see, then of course we should hit and try to see.
Absolutely.
Thank you so much, Dr. Rahul. It was a wonderful talking to you, and the panel discussion was really, really, really great and commendable.
Thank you so much. And learning from a hematologist, we are humbled as an oncologist. So it's a sister organization, both of us. So wonderful. I would also like.
I'll say oncology is a broader umbrella, and we are the smaller umbrella. And we all
both
have to work
umbrellas
together.
are important. I'll tell you, both are important, and it's really wonderful the way both the fields are evolving, and some, like they say, they are the futuristic branches, and so we're really wonderful to be in these branches. Thank you so much, Dr. Meet.
Thank you so much. Thank you so much.
And over to Akash.
Thank you, sir. Actually, it was our privilege to listen to you to speak and educate us on different therapy areas. And thank you for taking us, actually, both of you, staying from the first over till the 20th over for us. So an opening partnership that late till the end. Thank you once again for that insightful discussion. Surabhi, do we have any updates on Dr. Amit, sir?
Sir, there is some network issue from his end.
Okay.
Yeah.
So don't worry, we have
discussed quite a lot of things.
Dr.
already.
Akash, actually, Dr. Amit Upadhyay is on Indore airport. His
Okay.
network is really challenged there. So we tried to connect. Right now, his phone is also switched off.
Okay. No problem. So we will, then that means, Parag, we need to have a hematology update part 3, definitely. And we would love to listen to Dr. Amit. So
Definitely. Yes.
right. Thank you.
Thank you, Parag, for that update. And to the audience, that's a challenging situation with the field opening up, the hybrid model again looking has its own challenges. And so I think we can conclude the session now. But at the outset, I would really like to thank Dr. Rahul Sood sir for his time, for his insightful discussions and for his questions, and for his brilliant moderation of the case-based panel discussion. And thank you, sir. Thank you for your time. And also, I'd like to thank Dr. Meet Kumar sir for his insightful discussion on the role of BTKIs, especially acalabrutinib, in management of CLL, and also his experience with the drug in management of CLL as well. And also upfront, Dr. Aniket sir for taking us through the different high-risk factors in CLL and how they are prognosticated. And also Dr. Rajat Bajaj sir, who had to drop out unfortunately due to technical reasons, to showcase how the management of CLL evolved from the time of chemoimmunotherapy. So with that, I would really like to thank all of you for your insightful time, insightful for the discussions. And it's a privilege to have listened to you all. I think, Dr. Rahul sir, if you could conclude with few of your remarks, then we can.
Yeah. So my concluding remarks are as follows. Thank you, one and all. The field of oncology and hematology is ever evolving. The leukemias, lymphomas ever remain a challenge for us. But the way to go forward is to learn and sit with our pathology, molecular biology people, to learn from the hematologist, to learn from the patient itself that how the disease behaves. The older molecules have taught us, yes, the disease can be prolonged. The newer molecules have told us that the disease can be treated easily. We can get overall survival benefits. We can get an overall response. Acalabrutinib is, though a new kid on the block, but has shown promising data when it comes both to CLL as well as MCL. The biggest problem with both these diseases is that you have relapses of these diseases, and the relapse is a setback not just for the patient. You require a robust molecule for these individuals, and I think the BTK inhibitors, especially acalabrutinib, is the way to go forward for these. So with this, I would like to thank again the organizers, AstraZeneca. I would like to thank Lilac as well as Intas for the same. I would like to thank the entire team of Horizon, Surbhi, and Tarun for helping us with the technical part of it, and looking forward for the next part of it in the near future. Right, that's all from my end. Akash, over to you.
Thank you, sir. Thank you for that amazing remark. As we said, the nice statement, the new kid on the block, and hope it goes on for a further longer journey. And thank you once again. I think that we come to our end of this today's session. Thank you once again for joining. Stay safe and take care. Thank you all.
Thank you.
Thank you so much, sir.
Thank you.